All right, today we're tackling something huge, a massive update that is literally about to change how we all think about cholesterol. Yeah, that includes your doctor. We're going to break down the brand new 2026 guidelines.
So, you think you've got the rules for managing cholesterol down pat. You know your LDL, you're on top of your meds, you know your risk score. Well, get ready, because things have just changed. I'm talking a complete rewrite of the Heart Health Playbook, coming straight from the top cardiology groups out there.
So here's what we're going to cover. We'll look at this new playbook and why treat earlier is the new mantra. We'll dive into this new CPR method for figuring out your risk. And get this, specific goals are back. We'll talk about that, plus some new tests you probably haven't heard of. And of course, what it all means for you.
All right, let's kick things off with the big picture here. And I want to be super clear. This isn't just a few little tweaks. Nope. We are talking about a major, fundamental shift in the whole strategy for managing heart health.
And this is where it all comes from. The American College of Cardiology and the American Heart Association, the ACC and AHA. They've officially tossed out the old 2018 rulebook. This new 2026 document is the new standard of care, and believe me, it is packed with some absolutely crucial new ideas.
Okay, so let's get into what I think is one of the biggest philosophical changes here. It's this move away from just, treating a problem when it pops up and moving toward preventing it across your entire life.
And the main idea here is it's just so important. The guidelines are basically saying the real enemy isn't one bad cholesterol reading you get on a Tuesday. No, it's the cumulative damage. It's the total exposure over years and decades of your arteries to those, atherogenic lipoproteins. That's just a fancy term for all the bad cholesterol particles that build up plaque.
And check this out. This shows you just how early they want to start. I mean, we're talking about lifestyle counseling when you're a kid, screening toddlers as young as 2 years old if high cholesterol runs in the family. And then, get this, universal screening for all kids between 9 and 11. It's all about catching that risk super early and managing it for a lifetime.
Okay, so if the whole game is about treating risk earlier, how exactly are we supposed to measure that risk? Well, that leads us right into the next huge change, a total overhaul of the risk calculator that doctors use. For a long time, docs been using this thing called the pooled cohort equations. It's how they estimate your 10-year risk of a heart attack or stroke. Well, you can say goodbye to that. It's officially been retired. And in with the new. The replacement is called the prevent equations. Think of it as a much more modern, way more accurate tool that's actually designed for the population we have today, specifically for adults from age 30 all the way to 79. It's a whole new way to predict your risk.
And they've even packaged this into a super easy-to-remember model called CPR. It's simple. First, C is for calculate. You use prevent to get that 10-year risk number. P is for personalize. You and your doctor talk about factors unique to you that the calculator doesn't see. And R is for reclassify. If there's still some uncertainty, you might use other tests, like a coronary artery calcium score, a CAC score, to really sharpen that picture of your risk. All right, now for what might be the single biggest U-turn from the last set of guidelines. This is a big one. For years, the focus was just on the percentage you lowered your cholesterol. Well, guess what? Specific goals, they're back in the game.
So let's break this down. The old way was all about relative change, right? Like let's lower your LDL by 50%. The new way says, yeah, that's still important, but we're adding something absolutely crucial. We need to hit a specific number. See, for a while the thinking was just to treat aggressively, and that was enough. But what they found was that both doctors and patients kind of felt lost without a clear target, a finish line. So they're bringing back these concrete goals because the data is just overwhelming. The lower your actual LDL number gets, the lower your risk is. Simple as that. A clear goal just helps everybody get on the same page. And for people who are at the absolute highest risk, we're talking about someone who's already had a heart attack or a stroke, the goal is, wow, it's incredibly ambitious. They want that LDL cholesterol number below 55. That is a really aggressive target, and it's all about doing everything possible to prevent another event from happening. But hey, it's not a one-size-fits-all thing. Not at all. The goals are totally tailored to your personal risk level. So if you're considered high risk but haven't had an event yet, the goal's a bit different. It's under 70. If you're in that borderline or intermediate risk category, the target is under 100. This is exactly what we mean when we talk about personalization.
So to get this personalized, you've got to look deeper, right? And that's why the new guidelines are now recommending we go beyond that standard cholesterol panel you get at your yearly checkup.
First up is something called lipoprotein A, or just LPA. The easiest way to think about it is like a special type of extra sticky bad cholesterol. And the tricky part, your level is pretty much just determined by your genes. You're born with it. And if it's high, it can seriously increase your risk, even if all your other cholesterol numbers look perfectly fine.
Because of that hidden danger, the new recommendation is really clear. Every single adult should get their LPA measured at least once. Just once in your life to know your number. If it turns out to be high, it's considered a risk enhancer. Basically, it's a major red flag that tells you and your doctor, hey, we need to get way more aggressive about lowering all the other bad cholesterol.
Okay, the other big advanced test is for something called apolipoprotein B, or ApoB. Here's the best way I've heard it explained. If the bad cholesterol, the LDL, is the dangerous cargo, then ApoB is the truck carrying it. Every single one of those artery-clogging particles has exactly one ApoB protein on its surface. So when you measure ApoB, you're not estimating, you're getting a direct head count of how many of these dangerous trucks are driving around in your bloodstream. It's often a more accurate way to see the total threat.
Now, you don't always need this test, but it's super valuable in specific situations. Let's say you've hit your LDL goal, but your doctor still thinks there might be some residual risk, some danger left over. That's when you look at ApoB. It's especially helpful for folks with high triglycerides or diabetes, because in those cases, the standard LDL number can sometimes be a little misleading.
Whoa, okay. That was a lot of new info, I know. We've got a whole new philosophy on timing, a new risk calculator, the return of specific goals, and these advanced tests. So let's tie it all together. What's your next move? What does this actually mean for you?
So here are the 4 big takeaways from this whole new playbook. Number 1, start early. Heart health is a marathon, not a sprint. It's a lifelong thing. 2, get specific. You got to know your numbers, and I don't just mean your cholesterol. I mean your risk score and your specific LDL goal. 3, go deeper. Ask your doctor about those advanced tests like LPA. Seriously, just ask. And finally, number 4, partner up. Take this information and use it to have a really good, really informed conversation with your healthcare provider.
Look, at the end of the day, these new guidelines are like a brand new, much more detailed, and way more accurate map for that lifelong journey of your heart health. So the only question left is, are you going to use the latest map?